Well, hello everyone, and welcome to another virtual brain expedition. This brain expedition is hosted once again by the University Hospital Foundation. My name is Carolyn Thompson, and I am so very fortunate to serve as the Director of Philanthropy for the Foundation. I want to extend a sincere thank you to all of you out there for joining us this afternoon. Please note this session will be recorded, and we will send out the link to everyone who has RSVP'd over the next few days. We cannot hear you or see you, but we will be answering your questions or comments sent through the question and chat boxes. It is now my pleasure to introduce to you Dr. Jody Abbott, the President and CEO of the University Hospital Foundation, and a woman of vision who is as passionate about innovation as the two doctors we're going to hear from today. Jody?
Thank you very much, Carolyn, and good afternoon, everyone. Carolyn, you're absolutely correct that I am passionate about innovation, but not just for the sake of doing something different. Doing something better is what's important. That's why I'm so excited for all of you today, because you're going to meet two doctors who have made stroke care better at the University of Alberta Hospital. In fact, we've become one of the most advanced centers for stroke care in Canada, thanks to their efforts. And you know what? They'll be the first to tell you they could not have done it without the support of their community. So as you listen to them today, if you catch yourself thinking, they must be so proud of what they've accomplished, please know that if you've made a donation to the University Hospital Foundation, then you should feel proud too. This is an impact of your generosity at work. And if you're considering supporting our organization and would like to learn more about stroke care in your community and the role that our donors play in helping to make that happen, you couldn't have picked a better afternoon to join us. Every dollar we raise makes a difference to patient care, research, and innovation at the University of Alberta Hospital. The kind of research that led to the life-saving procedure that Dr. Rempel performs, where he physically removes a clot from the patient's brain to restore blood flow. Within seconds, his patients go from near certain disability or death to making a fist and responding to questions even while they're on the operating table. I'm not making this up, and he'll tell you those stories himself in just a minute. An innovation like the stroke ambulance, stroke care on wheels that can cut stroke to treatment time in half. What is stroke to treatment time? Exactly what it sounds like. The time between the onset or discovery of a stroke to when treatment is administered, usually in the form of a clot-busting drug, simply known as TPA. Let me tell you, for a person having a stroke, the more we can reduce that time between stroke and treatment, the better chances you have for a full recovery that you're going to hear about today existed. So when my mother had a stroke in 2010, those options were not available. The care she received at the University of Alberta Hospital was outstanding, but ultimately not enough. So this one's personal for me, as I know it is for thousands of other Albertans who have either suffered a stroke or love someone who has. Strokes are silent, they move fast, and they don't care who you are or where you live. The dedicated work of people like Dr. Rempel and Dr. Jeerakathil, together with support from the community, is helping to protect us. Just before we go to our presentation, I'd like to tell you a little bit about the University Hospital Foundation. We were created in 1962, and we raise funds to advance patient care and innovation at the University of Alberta Hospital, the Mazankowski Alberta Heart Institute, and the K. Edmonton Clinic. In the ensuing decades, we have evolved into one of the most successful healthcare fundraising organizations in North America. Thanks to the incredible generosity of our donors, we've established world-class cardiac and brain care right here at the University of Alberta Hospital, and we are home to Canada's most comprehensive transplant program. As you may have guessed, today's virtual brain expedition is about strokes. There are approximately 50,000 strokes every year in Canada, or roughly 1 every 10 minutes. When a stroke happens, 2 million brain cells die every minute. These are staggering numbers, and we're so grateful for the work of our medical teams who work every day to save more lives of stroke victims. To learn a little bit about how this audience has been impacted by brain conditions, we invite you to participate in a live survey. The results of the survey are anonymous and may give us a bit of a sense of what brain conditions you may have experienced or personally or family members have. Let's take a look. Jillian's taking a watch over the results coming in, and she'll let us know as we have results.
Great, thank you, Jody. We'll just give it a couple more seconds here for our guests to submit their answers, and I'll let you know in a few seconds.
Thank you.
Okay, here are the final results, Jody.
Wow, thank you very much. So as you can see from the results, family members, 47% of you online have been impacted by a stroke. And I know what happens there is not only is your family member impacted, but you are impacted both in care areas as well as the kind of support, including emotional support, that is required. And as I mentioned earlier, my mother passed away from a stroke several years ago. And that's one of the reasons we're so passionate about hosting these brain expeditions and sharing the amazing work of our medical teams with you. It's now my pleasure to introduce our two special guests. Dr. Tom Jeerakathil is an Edmonton-based stroke neurologist and professor of neurology and medicine at the University of Alberta. He has also played a critical role in the groundbreaking stroke ambulance project. And Dr. Rempel is an interventional and diagnostic neuroradiologist at the University of Alberta Hospital and a professor in the Department of Radiology and Diagnostic Imaging at the University of Alberta. As impressive as their titles are, it is their work in the field that has already saved lives and will continue to save countless more. They are true visionaries who have put into practice the very innovations they have worked so hard on to accomplish. And I'm glad they are here with us today. With that, I will pass things over to Dr. Jeerakathil.
Thanks, Jody. It's my pleasure to be here speaking to you today about something I spend a lot of my time working on, which is stroke. So I want to start with a scenario, and this is a patient that, with a few details changed, that I would have encountered on call maybe a few months ago. A 69-year-old male business owner with high blood pressure. He awoke in the middle of the night feeling unwell with no actual symptoms other than a feeling that something terrible was happening, and he asked his wife to call the ambulance. When the ambulance arrived, they already found him unable to speak. He was developing paralysis of the right side and was unable to move the right side over minutes. He was unable to see out of the right side of his eye. And he was in rural Alberta at the time, more than 150 kilometers away from Edmonton or a tertiary care center. So this situation plays itself out across Alberta about 5,000 times a year. And it would be this severe maybe about 1,500 or 2,000 times a year. So stroke is a major problem worldwide. It's a leading cause of disability in adults. Of the 70 million people in the world that die every year, 1 in 10 are from this single disease. If you consider there's thousands and thousands of diseases, it's remarkable that one disease would cause so much burden. And the cost to Alberta is in the range of $300 to $400 million per year. And if you hold up your hand, just to keep it simple, and there's 5 people who have a stroke, 1 dies from it, 1 goes to a nursing home because of it, 1 has moderate disability and might go home, 1 has mild disability and could get back to work, and 1 is fortunate enough to make a complete recovery. But almost half of the people that have a stroke have an outcome that most of us would not want to have. And one of the reasons why it's difficult to treat stroke, well, these 2 pictures will show you. A lot of you, I wonder if most of you could tell me what's going on in this picture here. I think a lot of you would say, well, this man's having a heart attack. He's clutching his chest. He's able to tell somebody that he's having chest pain. And the bystander knows exactly what's going on, has a cell phone, and calls for help. And contrast that with this situation. And in this situation, we have a gentleman who's found by a bystander slumped over. Those of you who have experience with stroke in the audience might recognize a facial droop and the fact that the left arm really isn't moving and has no tone. But really, the bystander has a lot of difficulty even figuring out what's going on. Is this what this individual's usually like? Did they ingest some kind of substance? What exactly is going on? And this pretty much illustrates the challenge of stroke. And the other challenge is this. Without this imaging modality, which is a CT scan, you can't tell what kind of a stroke a person is having. The patient that I just described to you might be having this kind of a stroke, which is a roughly golf ball-sized bleed in a deep area of the brain, producing the symptoms that I initially described. This is another kind of hemorrhagic stroke, another bleed in the brain. And right here, this little white dot is actually an aneurysm that ruptured, causing blood to spill into the fluid around the brain. And so you can't give certain treatments to this kind of a stroke. Therefore, you have to know what kind of a stroke it is, and you need a CT scan. But about 80 to 90% of strokes are this kind, where you see here, this isn't actually blood over the surface of the brain. This is a clot inside of a blood vessel. And this clot is about 5 centimeters long, or 4 anyway, and it's causing a lack of oxygen flow to most of the left side of the brain. And this is an ischemic stroke, which is the most common kind of stroke. And as it turned out, the patient who I talked to you about on the first slide had this kind of a stroke. And it's a big problem because in this kind of a stroke, you lose 1.9 million brain cells, 14 billion brain connections or synapses, and 12 kilometers of nerve fibers every minute that artery is blocked. And this process is going to continue until your nice gray, healthy brain tissue on CT scan is black and that tissue has died. And the average stroke ages the brain approximately 30 years if you think about neuronal loss. So what can we do about this? So there are a number of things we can do. And they center around, our strategies against stroke are technology, people, innovation, and organization. And a lot of this comes to us from a background of research. That's how we actually get these therapies, through research, through learning and studying and figuring out how to actually make better technology, have people with better skills, and change the system to innovate in how we organize things. So on the note of organization, even if you don't use any kind of fancy technology, if you organize care for stroke patients in a stroke unit, you improve outcomes substantially for every single stroke patient that enters that unit. And why? It's because a stroke unit has healthcare professionals that have interest in training in stroke, standardized order sets to actually provide patients with important care that they need, organization of wards such that patients and their families can actually help in the recovery process, and meetings between all the different healthcare practitioners and each other and the family and the patient to actually coordinate the care that the patient receives. So a stroke unit alone is just organization of services and training and skilled people, and that actually improves outcomes. But a stroke unit's not enough. We really want to go after the problem, which is the blocked artery. So enter molecules. So tissue plasminogen activator, or TPA, is a medication which is basically, think of it as Drano for the arteries. It basically goes into the arteries, goes into the artery that's blocked, finds the clot, and chews it up microscopically to try to restore blood flow. And TPA, or tissue plasminogen activator, has been around since about 1995. So fortunately, we've had this treatment for stroke for the last 25 years or so. But there's a catch, and that is this graph represents the degree of benefit you get from the clot-busting drug. And as you can see, as the clock ticks, that benefit is decreasing over time. And then at about 4.5 hours, there is no benefit that you can get from giving the drug. The damage is already done. So it's challenging, though. You need a CT scan. You need to diagnose a patient who may have a complex syndrome. Often stroke overlaps with other conditions in terms of the clinical presentation. So how do we actually treat stroke quickly? Well, in Alberta, we've used organization again. And so it used to be that there were 5 clot-busting centers in the province, covering about 30% of the geographic area in 2005. Through our provincial stroke strategy, we went to 18 clot-busting centers across the province. And we do this through the Northern and Southern Alberta telestroke systems, because there are no neurologists in a lot of these different places. And we do this through telehealth. And this is my colleague, Dr. Khan, seeing a patient in another city using telehealth. Now everybody does telehealth. It's called Zoom. Since COVID anyway, a lot of people have gotten a lot more comfortable with this. But these are hardwired connections, which we're able to actually have a very high degree of resolving power. We can even examine eye movements sometimes with this kind of technology. And so this is how we've done it across the province. And we've done a lot of quality improvement campaigns, because the treatment of stroke is so complex that we need every site to treat people as quickly as they possibly can to give that patient the best chance of recovery. But even despite our quality improvement efforts and putting in all these stroke centers, there are still areas of Alberta that have slow service in regards to getting access to stroke treatment. And these are the southwest, west, the north, and the east of the Edmonton area. All right, these areas, if you originate in these areas with a stroke, it's very difficult to get you to treatment fast enough. So therefore, it's much more difficult to allow you to have a good recovery if you originate in those areas. So as a solution to that problem, we looked overseas to the Germans, actually. They were the first people to put a CT scanner in an ambulance. And it was actually the Hamburg group that did this. And they created an ambulance that could be dispatched in a city and actually see patients with stroke, scan them. They had telehealth hookups to allow doctors in the hospital to examine them, and then deliver clot-busting medications in the field. And we thought maybe this model of care could actually help us with rural patients in particular. Mobile stroke units are highly specialized ambulances with the different features I mentioned. They basically bring the hospital to the patient rather than the patient to the hospital. And they have a specialized stroke team that staffs them, a very highly variable composition across the world. There are probably about 20 of these vehicles in the world right now. And they expedite very timely stroke assessment and treatment. Germany was the first. A number of others across the United States and now across the world have done this. And they deliver faster care from stroke onset to treatment. So we launched the Achieve project, which is Canada's first stroke ambulance and the world's first stroke ambulance that actually delivers care to rural areas. So there's no other one in the world that did this up until this one. And we assembled a number of different people. There were over 100 people that helped us organize this vehicle, from Alberta Health to rural physicians to paramedics to dispatch experts. All these different individuals helped us to organize this vehicle. We did simulations in simulation areas in Calgary when we set it up, because the adventure of going into rural areas with this vehicle was a new thing for the entire world. The way it works is a patient will come into a local hospital, let's say 100 kilometers away or up to 250 kilometers with stroke symptoms. And the physician on duty recognizes that this could be a stroke and activates the stroke physician at the university hospital. We have a very organized stroke dispatch system across Alberta. If you're having a stroke in Alberta, we're probably going to know about you very, very quickly after it starts because of the system that's been set up. When this happens, we then dispatch the stroke ambulance from the university hospital. The two vehicles meet halfway. So it's that physics problem you hated in high school. If a train leaves New York at 60 miles an hour and another one leaves Rochester at 50 miles an hour and they meet halfway. Well, the point is you shave the time, you cut the time in half to the point where you can actually get to and treat the patient. And so once the vehicles meet up, we move the patient into the stroke ambulance. We do a CT of the head. We video conference from Edmonton and examine the patient. Sometimes the stroke faculty is actually in the ambulance and we don't need to video conference. And then we give clot busting drugs if appropriate. And then we bring that patient to the university hospital for further care. And our vehicle is one of the largest teams in the world. And it's because of the rural issue. We have a primary care paramedic, an advanced care paramedic, a specially trained nurse, which is usually an emergency room nurse, a CT technologist, a trainee, a neurologist trainee who's training in stroke called a stroke fellow, and the stroke neurologist who's usually on video conference and located at the university hospital, but sometimes the stroke neurologist goes in the ambulance too instead of the fellow. And we have a CT scanner, a portable lab, video conferencing equipment, a leveling system, because on snowy Alberta roads, unlike Houston, for example, we don't have level roads when they're covered in snow and ice. So we have to level the system because it has to be perfectly flat to scan. And we have a 5-person cab. We have TPA, other medications, the usual monitoring equipment, a ventilator, a number of different things. And it's a full ACLS level ambulance. So the ambulance is actually lent support to basic life support crews at a number of times, even ones that didn't have stroke. And this is our CT scanner, which is a head-only CT scanner. And people can actually usually see me on the screens at the back of the vehicle if the patient's actually lying on the stretcher. And we also have a screen on the ceiling. So if the patient's lying flat, they can see me as well. And there's the vehicle. And we have the University Hospital Foundation to thank for actually delivering this vehicle to us. Sometimes it was amazing to actually see it in the steel and rubber after all the time that went into planning it. But it is here, and Canada's first stroke ambulance at this point in time. This is our catchment area, which is 250 kilometers around Edmonton. And again, we usually don't drive that whole distance. We meet halfway. But we also service, through different phases of the project, we actually service the Edmonton zone and actually the greater Edmonton area as well. So we are actually a mixed rural-urban service model. And one of the reasons why I got interested in the project, in fact, the Dr. Schwabe, who's one of the leaders of the project, he had the idea of doing this when I was a resident back in 1997. And I used to make fun of him about it. I'd call him, "Oh yeah, you're stroke Winnebago." And I thought it was just completely off the charts. Nobody would ever do anything like this. It wouldn't make any sense. But when I got involved in the project, and I've got some degree of health economics background, I thought there was an incredible economic opportunity here, as well as an ability to improve outcomes and actually save money for the system. And in fact, mobile stroke units or stroke ambulances could deliver a return on cost of from 2 to 5 times what you actually spend on the vehicle and what it costs to operate the vehicle. If you look at the amount of disability you're saving, because you're giving people better outcomes by treating them faster. So there's a great opportunity here. But it is out of the box thinking, and it is very challenging to get novel projects like this going. And so we thank the foundation for funding it. So technology in general has helped us in stroke. So in the past, you'd give a clot busting drug or any intervention and you wouldn't know what the effect was. Now we can peer into the brain and it helps us to treat the brain. And here what we see is the same patient I told you about in the first slide. Now seeing them hours after the clot busting drug was given, still has a blocked artery. And additional advanced imaging actually shows us an area of the brain that's got interrupted blood flow. This brain tissue has interrupted blood flow, and it shows us the brain that's actually died. well, only a tiny amount of this area has actually died. So there's a lot of brain to save for this patient still. So what do you do when you've given the clot-busting drug and the artery is still blocked? Well, it happens about a quarter of the time. Well, you call a man whose title is longer than my last name, a neurointerventional radiologist, so Dr. Rempel. And so I'm now going to pass the presentation over to Dr. Rempel, and he's going to tell you about what he does when the clot-busting drugs don't open the artery.
All right, I'm just going to give a few seconds for the system to catch up. But just want to tag on to what Dr. Jeerakathil was saying and how the stroke ambulance is such a fantastic innovation that we have at our disposal. And it gets that clot-busting drug, that TPA, into patients faster than we could imagine. But the vast majority of stroke patients are going to benefit from that TPA. But the patients with the biggest strokes, with the biggest amount of blood clot in the brain, are the ones that TPA often has trouble dissolving it, and mostly just from that there's just too much blood clot for the TPA to work on. And that's really where the procedure that I do, called an endovascular thrombectomy, or a stroke thrombectomy for short, it really marries or meshes very well with kind of the TPA treatment. And that's where the stroke ambulance not only gives TPA in the field, but as that's happening, they're rushing the patient to the university hospital as fast as they can for those big, bad strokes that TPA is not going to work on. And when we get patients into the hospital, we do the CT scans and assess whether there's still a big portion of brain that's salvageable, that could rebound and return to normal function. That's when Dr. Jeerakathil and his team will often give me a call and say, hey, is there something that we can do? Can we bring this patient for a thrombectomy? So what I want to start with is show you a little animation of what a thrombectomy actually does. So this is a little video that'll start here, and this shows all of the blood vessels in the neck and the brain. And how we start treating these patients is to gain access to their vessels, which is usually by putting a catheter into their artery down in their hip. We get a tube all the way up into their neck, and then here's a picture of the brain, and this is showing that blocked artery. And we have a little wire, so this dark line is a micro wire that we can advance up into the brain through that clot and way out into a small vessel that's feeding in this case, the left side of the brain. And here's what we call an intermediate catheter, or an aspiration catheter. Here's a bigger catheter. There's all kinds of catheters of different sizes, and I'll tell you what these are used for in just a second. And you can see the complex anatomy, the corners that we have to go through, and this is pretty typical anatomy in the brain. And then finally, once we're all up to the clot, we place a microcatheter, so a catheter that's roughly about 1 millimeter, or just over 1 millimeter in diameter, and we can push that through the clot. Now, these clots are usually like jello; they're not concrete, but they're there to blocking the blood flow. And then through this catheter, we can deploy what's called a stent triever, which is a wire mesh stent, and we use stents all over the body. Some people have stents in the blood vessels in their heart or in their abdomen. So this is a slightly different kind of stent. It's very smooth, very soft, and we can deploy it into this jello-like clot. And unlike stents that are placed elsewhere in the body, this is not a stent that we leave behind. We deploy it, and it's attached to a wire that's actually extending out of the patient. You can see here that the blood flow has been partially restored simply by just deploying this stent. And that's because the blood clot's kind of getting pushed around the outside of it. And we leave this up for several minutes, and that clot basically incorporates itself or gets stuck to the stent, and then we can pull it out of the body like this. And usually with that larger tube that you see left behind, it's aspirating the clot as well, or sucking it out so that we don't have anything flying off into the brain. And usually this whole process, it takes almost no longer than this video. So I usually leave that stent up for only about 2 minutes before we pull it down. And oftentimes, where the technology has improved over the last 5 years, that in greater than 50% of the cases, this is how long the case takes. My record is about 15 minutes. I think I had one case where I was start to finish in 12 minutes, where we had someone with a massive stroke, a huge blood clot, and complete restoration of flow to the brain within 10 minutes. So that is absolutely remarkable. And what's fascinating is most of the time in a lot of stroke patients, there is a huge portion of the brain that is simply stunned. For example, it's not dead, but it's in a state of being frozen. So if we can restore blood flow rapidly, that frozen part of the brain can be turned back on. We can regain that function. Which is why sometimes people go from not speaking and not moving to looking at you on the table a few seconds after this happens and saying, hey, what just happened? Speaking fluently and moving their body again. That's not necessarily the expectation, but it has happened many times. What I want to show you here is, this is a picture of our angio suite, so one of the 2 biplane angio suites that we have. If we just give me a minute here, I'm just going to get a marker to show you what I want. So what we mean by biplane angio suite is bi is 2. So this is one arc. So this C arc is one of the machines, and the other one is here. So there's 2 machines that give us 2 different views of the brain. So in this is a live case. The patient's head is on the other side of this shield. This is me. This is one of my colleagues, Dr. Chow. And this is about where the patient's waist is. And there's a tube coming out of their artery. And my hands are on this catheter that's basically down working by their knee and their foot. So to put it in perspective, I'm working at someone's knee with a tube in their brain and watching everything on this screen here. So I often say, I joke around with my son that I just play video games all day long. Because really, this is just real life video games. And here's a live picture. So if we would have taken this view, I'm going to show you what I'm looking at on this screen. So if we go like this is a kind of the first picture of a stroke case. So this is the same picture. It's just the reverse or the inverse of what Dr. Jeerakathil was showing you. And there's a blocked artery right here. There should be all kinds of vessels over here, but there isn't. So this is what we call an M1 occlusion. So one of the most common strokes, big strokes that we see. And after we deployed our devices, we removed that blood clot, we were able to result in this. So this is the same patients 5 minutes apart. So that's where the blood clot was, right where my cursor is. And all of these blood vessels are now filling with blood where before they were not. And so this is just a real life case of basically the dramatic pictures that happen when we can treat stroke in this manner. Now, the other thing I wanted to talk about is that the biplane angio suite, so we just go back to the picture of the angio suite. This is not just a stroke or a thrombectomy operating room. This is a minimally invasive neurosurgical operating room where one of the most common things we do now is treating stroke. But we also treat a lot of the hemorrhagic versions of stroke that Dr. Jeerakathil talked about. So ruptured brain aneurysms, ruptured vascular malformations, carotid stenting procedures where there's a stroke is caused by a blockage or a narrowing in the vessels in the neck. And there's a list of many, many different types of operations that we perform with the benefit of this room. So you can imagine that someone like myself or one of my colleagues, this room is being actively used for patients the majority of every day. So a number of years ago, this became a bit of a concern when endovascular stroke thrombectomies really became starting to take off was, well, what happens if I'm in the middle of coiling someone's ruptured aneurysm, which can be a 2 to 3 hour surgery, and we've got an acute stroke patient waiting down in emergency, and Dr. Jeerakathil calls me and says, hey, we need a thrombectomy now. Well, I'm stuck for the next 2 hours. And in the majority of hospitals in Canada, the reality is that in those circumstances, the patient might actually have to wait. And we've heard how many brain cells are dying per minute, not per hour, but per minute. So a number of years ago now, and sorry, I'm going to have to get the hospital foundation crew to let me know, is it 3 years ago or 2 years ago that we installed our brand new biplane suite, which is basically a mirror image of this one, simply just down the hall. And so now we have 2 of these fully functioning operating rooms. So if I'm in here doing an aneurysm coiling, one of my colleagues can walk down the hall and treat a stroke while I'm still finishing treating this patient. So it's wonderful to know that we are basically never closed to stroke. A stroke patient should never have to wait or have more brain lost because there isn't a facility that can treat them. The key is getting them to the university hospital. And that's the big key. So I just wanted to show you one last picture here too. So this is just an example of an aneurysm. So very similar picture, right? So carotid artery, middle cerebral arteries, but this little bubble shouldn't be there. And that's what a classic brain aneurysm looks like. And this is a patient of mine from, I think, about 6 months ago. So with a similar tools, similar devices, after a few hours, we ended up with this. So now you can see that there's no more black going into that aneurysm. So this is what a coiling looks like, where we are able to deposit a number of little platinum coils of varying sizes to block the blood flow into that aneurysm and prevent it from potentially bleeding in the future, which can cause one of these bleeding strokes that we had talked about. And so that's just another example of a procedure that we do in the angio suite. And just to sign off on my side, you all can't be with us today, but this is just an example of when we had Mr. Wayne Gretzky with us a few years ago, showing, and he was basically, we're standing right next to the table that I showed you in the first picture, and just showing him an example of a few different stroke devices and giving him a tour of our suite. So I know there'll be opportunities for questions later. I'm more than happy to answer them when they come up. But I'll hand the reins off to the next person in line.
Stroke can affect any age group. It does not care how old you are. It can affect anybody. It can affect you typing on your computer. It can affect the 80-year-old walking down the street. To recognize a stroke, we often will tell people to use FAST. Face, you smile, is a face symmetrical. Arms, lift up the arms, is one drifting. S, slurred, is the speech slurred or garbled. T, time is brain. 2 million neurons are lost per minute when you have a stroke. So it's important to act quick. As a leading treatment for stroke, TPA, it can only be given within a tight window. So 4.5 hours from onset of symptoms.
This is Canada's first and only stroke ambulance. So what we have here that you don't find on any other ambulance is we have a CT scanner. It takes about 70 seconds for us to do our imaging. The images go from this scanner, they go over to this laptop. The images are then sent from this laptop, they're sent back to the university hospital. We can send about 100 images in just under a minute. And this system is good that we can be 250 kilometers away from the hospital and it still functions and everything's done in real time.
The stroke ambulance has proven that we have 80% good outcomes compared to 52% standard care. The average door to needle time with our ambulance is 23 minutes. Basically, if you're gonna have a stroke, this is the ambulance you want coming for you. The only reason why the stroke ambulance exists is through the tremendous support from the University Hospital Foundation. Without donors, this wouldn't even exist.
We're in the diagnostic imaging department now with Dr. Jeremy Rempel, who's a neurovascular interventional neuroradiologist. Can you tell us why an interventional suite has become such an integral and important part of a brain center?
Well, as you can see, we call this a biplane angio suite, which means it's got 2 X-ray machines. And just this is an example of a cerebral angiogram behind us. And you can see the complex anatomy inside the brain. And something like this is necessary for us to safely navigate the brain. But more than that, why it's critical now is that we have so many minimally invasive techniques to treat brain disorders, anything from a ruptured aneurysm to stroke. And it's all being done with a machine just like this. The stroke ambulance is critical to getting a first-line treatment, so TPA or something, a lytic drug that can be given through an intravenous as fast as possible to a patient. But in addition to that, they're speeding up the time that the patient can get to this hospital. So unlike IV TPA that you can put in a fridge and into an ambulance, this suite is only here. This is the only hospital in Northern Alberta that has not one but two of these. So it's critical to get the patients to this hospital as fast as possible. And that's where the stroke ambulance really helps. We do an angiogram. So first of all, that's getting a tube into someone's artery, usually in the leg, and going up into the brain. So this is a typical picture that we might get. So someone having an acute stroke, oftentimes this artery right here would be completely blocked, which means that none of this part of the brain would be filling with blood as this picture is showing. So in order to restore flow to that, we use a combination of techniques, but the most common is called a stent retriever. And I actually have an example of one right here. I'll push it out so you can see. So this is literally what we would do with this type of a catheter in the brain vessel. So we deploy this little stent. So that's this is the exact size and shape of stent that we would deploy in someone's middle cerebral artery, which grabs the clot. And then with some aspiration on our guide catheters, this can be dragged out and this clot comes with it, essentially restoring normal flow within sometimes minutes. It's more common to see amazing recoveries than you might even think. The one that sticks out in my mind the most was actually when it was close to when I started working here. The patient had an occlusion of their basilar artery, which is one of the main blood vessels that feeds the brainstem. And fortunately, the patient was breathing on their own, but when we deployed the stent, it actually kind of squished the clot around to the outside of the stent and temporarily blocking flow to the patient's brainstem. So unfortunately, within seconds, they stopped breathing on the table. So we acted quickly, pulled that clot out, and immediately the patient took a deep breath and basically started talking again.
Thank you. Thank you so much. Thank you, Dr. Jeerakathil and Dr. Rempel, for taking us through this very exciting and very educative world of advancement in stroke care right here in our city. We will now move to our Q&A session. By the way, my name is Prince Ostay. I'm a philanthropy officer here at the University Hospital Foundation. This is a time where you actually get to ask the doctors the questions you have. And we have allocated about 10 minutes for this session. So right at the bottom of your screen, you should see a Q&A tab where you can type in your questions. I will do very well to read them to the doctors. And should we not have enough time to answer every question, we will respond to you by email once we send the video out for the recording. And so I see there is a first question here. And so our two doctors will decide which one of them would answer the questions. So the question came from Alexandra, and she's asking, how many brain cells die in a stroke?
Do you want me to take that one, Jeremy?
Go for it.
So on the average, 1.2 billion brain cells will die in a stroke. So you have 100 billion brain cells. Of those, 22 billion are neurons, and about 88 billion are support cells or glia. So other kinds of cells, not actual neurons. But in the average stroke, you're going to lose about 1.2 billion brain cells.
And we did get some questions ahead of our presentation today. So one of the questions that came was, do our eating habits and our lifestyle affect the onset of stroke in any person's life?
I can take that one too. And the answer is definitely yes. So there are a lot of elements. We can talk about lifestyle first. So if you can exercise half an hour, 5 times a week, you'll drop your stroke risk by 45%. If it's a little bit more than that, some studies have found up to an 80% reduction in future stroke risk just from exercising regularly throughout the week. Smoking will increase your risk of a stroke by about 9 times. Depending on the amount you smoke, it can be anywhere from about double to anywhere from 5 to 8 to 9 times higher risk from smoking, depends on how much you smoke. And then in terms of diet, it's more known what kind of diet would reduce stroke risk than increase it. But you can assume that the reverse of this would increase stroke risk. But if you have a diet with fish at least once a week, it's associated with a reduction in stroke risk. If you have fish up to 3 times a week, it's an even larger reduction in stroke risk. If you have fiber, for every 1 gram of fiber you eat a day, you drop your stroke risk by 1%. So if you're eating 15 or 20 grams of fiber a day, it's correlated with a similar reduction in stroke risk. The only good news I get to give, coffee. So coffee, 2 cups a day, is associated with a reduction in stroke risk. It's not the caffeine, because decaf also works. It's the antioxidants. There you go. Jeremy's got a big glass of coffee. So yeah, it's the antioxidants. Tea also works. So we think it's antioxidants within those compounds that actually do that. There's going to be an upper limit where it's probably not doing you as much good, but a couple a day, 2 to 4 probably even, is a reasonable amount and is associated with a reduction in stroke risk. And then beyond that, it's a diet high in fruits and vegetables. So high in fruits and vegetables is also associated with a reduction in stroke risk. And on the average, the most studied diet in terms of reducing cardiovascular disease is the Mediterranean style diet. So that's fruits a few times a day, vegetables a few times a day, more white meats, but there's lean red meat that you can eat as well that's also healthy. But the Mediterranean style diet is probably most associated with a reduction in stroke and heart disease.
In terms of lifestyle?
So the main lifestyle piece is exercise. Okay. Body weight, so increasing body weight is associated with an increase in stroke risk, and this is not necessarily fair. So for North Americans, big guys like Jeremy, so you got to have a body mass index of 30 or more to start to get an association with risk factors that could cause stroke. But for Asians, so South Asians or East Asians, unfortunately, the body mass index that we have that starts to associate with risk factors is 23.5. So when our BMI goes above 23.5, our risk starts to go up. So people who from those ethnic backgrounds, including myself actually, have to be more cautious about risk factor control because the body mass thing is not necessarily fair. Drug use is dangerous in regards to causing stroke. So obviously intravenous drugs, as you would imagine, increase stroke risk. Cocaine, crack, and similar compounds, and actually amphetamines have an association with stroke risk. So I will see healthy people with good body compositions, and they have strokes, ruptures of their aortas, and heart attacks from cocaine and similar compounds. So to avoid drug use is a good lifestyle choice to avoid stroke and heart attack. And what else can I tell you about lifestyle? I think that's mostly, those are the major things. Avoiding sitting. So you want to get your 10,000 steps in a day, ideally, and that's just, a bit of a ballpark. You want to be active throughout the day, generally active throughout the day, in addition to your 5 exercise sessions a week. They have an additive effect. So if you do neither, you have an increased risk. If you do both, you've got an additive reduction in risk.
I almost got up from my seat.
Yeah, we've all been sitting here for now.
So the next question comes from Warren, and he's asking, what is the difference between a stroke and a seizure?
So I can take that, or Jeremy, you can too if you want.
Fair enough for both of us.
Yeah, that's right.
How about I'll give you your voice a break.
Okay.
So the biggest difference between a stroke and a stroke is where a part of the brain has been either damaged or there's a lack of blood flow or lack of oxygen to those cells. So either the cells are dying or like I'd mentioned before, stunned. So there's a chance of recovery, but a completed stroke would be an area of brain tissue that has died and is no longer functional. Whereas a seizure is often an area of irritation to the brain. And so the classic seizure would be a grand mal seizure where someone's shaking uncontrollably, but there's minor, more focal seizures that can happen as well. But that's usually related to anything that can irritate the brain. So that could be anything from a small stroke. So stroke patients can have seizures while they're recovering. It could be from a tumor, an infection, all kinds. So anything that can irritate the brain. So they can be similar in many cases, where the symptoms of an acute stroke or an acute seizure could mimic each other, but they are distinct entities.
Thank you. And Scott is asking, what would the advancement in stroke treatment do to help Alzheimer's patients?
So that's a very, very good question, because that's dementia is something that's becoming an increasing burden for our society, and something that a lot of people have personal experience with in terms of relatives, friends, and family members. And we have very few treatments to prevent dementia. But one of the best things you can do to prevent dementia is to prevent stroke. So what actually happens is Alzheimer's pathological changes in the brain interact with ischemic damage to the brain that occurs over time. By ischemic, I mean problems with blood vessels. And that can be at a microscopic level. So we'll see the damage in terms of changes in the white matter in your brain. We'll see sort of chronic lesions in the brain that suggest that your brain's not that healthy because of its blood vessels, or you'll actually get strokes that we can see, large areas of brain damage. And these strokes actually interact with Alzheimer's changes in the brain to actually bring on the dementia. So you could actually go through life without getting dementia, or maybe not having any symptoms, but the strokes actually bring the dementia out. Now that's for a lot of people. A lot of people have a mixed vascular plus Alzheimer's type dementia, but there are people with pure vascular dementia. Their dementia is just from the strokes. And there are these people with pure Alzheimer's where we don't see a lot of blocked arteries, but the Alzheimer's disease itself brings on the changes. But for a lot of people, you've got this, there's this background of Alzheimer's changes, which may never become symptomatic, if not for the effect of risk factors and the contribution of stroke or tiny strokes to the brain.
Okay. The next question is from Rod, and he's asking, what are the commonest circulatory and system disease responsible for causing stroke?
So I can talk about the heart, Jeremy, if you want to talk about the neck. How's that sound? So there are about 1 in 5 strokes is caused from some problem with the heart. So there's a rhythm problem or some kind of a disturbance with the heart, and that actually causes a clot to form in the heart, and then that clot breaks off and causes a stroke. And there's one called atrial fibrillation, which is probably the biggest cardiac cause, and that actually increases in risk as you get older. And over 80, it becomes a much more important cause of stroke than in younger people. If you've actually had a heart attack, a severe heart attack, where your heart wall muscle is not beating properly or not moving properly, you can get clots that stick to the wall of the heart. Those clots can break off and cause a stroke. So the heart can certainly be a cause of stroke, but then of course blood vessels can cause stroke too. And I'll let Jeremy talk about that because he also deals with those.
Yeah. So the next form is plaque buildup or areas of vessel narrowing, and that can happen in the heart, which leads to heart attacks, or it can lead in blood vessels that feed the brain. And one of the most common ones that I treat is something called carotid stenosis. And the way I describe that to most patients is pretend you're in your backyard watering your garden. And you've got a watering hose that you just turn on. And so the water flowing out of the garden hose is what a normal artery should be like. But what happens when you stick your thumb over the end of that garden hose? So now you can spray that water across the yard, and it's more bubbly and frothy, and that's exactly what can happen in someone's neck. So imagine they have a tight stenosis, and the blood is still trying to get through that pinhole, but now it's frothy and turbulent, and that turbulence can lead to tiny blood clots forming, or sometimes even large blood clots forming. And if that were to fly up into the brain, it could block a blood vessel and cause either a TIA or a temporary stroke symptoms, or even a much more significant stroke. And so we often treat those small strokes or warning strokes or TIAs with some sort of procedure to open that artery. So either a stenting, where we can use a similar but different stent than I showed you for the thrombectomy to stretch that artery open, or there's a surgical procedure called an endarterectomy, where they would do an incision into the artery, clean it out, and then suture it back together.
Okay. And we have time for the last question. Are patients with other neurological conditions, we talked about Parkinson's and dementia, more likely to have a stroke?
So I would say for the most part, probably not. Those diseases don't actually increase your risk usually of having a stroke. But as you get older, you're more likely to get these conditions, and you're also more likely to get stroke. So sometimes these conditions will definitely coexist with stroke, but the biggest common risk factor between them is probably the fact that many of them occur in people as they get older, and that's why you'll sometimes see them both happening in the same people.
Okay.
I'm just going to touch on that topic as well, because we often do feel that or hear about stroke being much more common in the elderly, and that's true, but that doesn't mean that younger people cannot have a stroke. So, for example, I did a thrombectomy on a 20-year-old gentleman just 2 weeks ago. And not only that, I'm in the process of developing a program at the university to offer this type of treatment to children down as young as 4 years old. And now the reasons or the etiology of stroke in these younger individuals is very different than in older individuals. It's often from an injury to the artery or an accident or some other problem, but strokes do happen in younger individuals, and oftentimes similar treatments are available. And maybe that is this Prince, is this our kind of the last question that we have time for?
Yes.
Yeah, and maybe I'll leave it just with Dr. Jeerakathil, but just to tie it into kind of our current pandemic, even with COVID-19, we've seen. Not necessarily me personally, that's why I'll maybe let Tom discuss that, but there has been reports that COVID-19 can increase the risk of stroke in younger people.
Jeremy, that's absolutely the case. COVID-19 seems to be associated with something called the antiphospholipid syndrome. So where you actually get activation of the clotting system. So places that had a lot of COVID cases like New York had very young people coming in with very large clots in their brain and otherwise almost no symptoms of COVID. So it varies, but it definitely seems to do this. Other groups that actually, when people were admitted for COVID just over a few days, they found rates of stroke of up to 4% to 5% just over several days of an admission. So the virus does seem to increase, seems to have an association with stroke and heart attacks.
Thank you so much, Dr. Rempel and Dr. Jeerakathil, for this lively discussion. Thank you so much also to the audience for making this very lively. I will hand over to Caroline.
Well, thank you, Prince. And on behalf of the University Hospital Foundation, including Dr. Jeerakathil, Dr. Rempel, Dr. Jody Abbott, Prince, Jillian, and myself, thank you so much for your time and your active participation. We hope you found today's session informative. And within the next few days, we will send you a very short survey, which we hope you'll complete. And let us know what other areas that you'd like to explore with us virtually. We will be sending you the recording from today's brain expedition. So please feel free to share this with your family and friends. I'm just getting a note that my video wasn't on. If you want to learn more, please do reach out to a member of the philanthropy team. And as Dr. Jeerakathil mentioned, the stroke ambulance is the work of the University Hospital Foundation and our donors. And we do need your continued support to keep the stroke ambulance on the road and to continue to bring advanced technology to the University of Alberta Hospital site. The role you play is invaluable. And if you would like to learn more, please do visit our new website, give2uhf.ca. And another way you can support brain care is through the University Hospital Foundation's Festival of Trees 50/50 Draw. Tickets for the 50/50 Draw are available now at festivaloftrees.ca. But hurry, the last day to buy your tickets is December 23rd at 11:59 p.m. And finally, we leave you now with a 1-minute video entitled, "What if you could actually save a life?" Thank you so much for coming tonight and enjoy your evening. Bye-bye.